Imagine finding out that the gold standard medical treatment, the one you take to cure your daily, just debilitating pain, could actually increase your risk of breast cancer.
Right. And not just while you're taking it, but for an entire decade after you stop.
Exactly. For like 50% of women going through menopause, that isn't some abstract, hypothetical thing. It is the very real calculus of traditional hormone therapy.
Yeah, it completely shifts how we have to look at treatment. I mean, when the established standard of care suddenly carries a long-tail risk profile like that, you are kind of forced to look at radical alternatives.
Which is exactly why we are here today. So welcome to this deep dive. For you listening, our mission today is to, well, to cut through the marketing hype and the internet rumors.
And there are a lot of rumors.
Oh, so many. We want to extract the actual science regarding a treatment you might have heard of, the O shot. Like, can platelet-rich plasma or PRP genuinely relieve menopausal symptoms?
Right. And we have a massive stack of sources to get through to answer that.
Yeah, we're looking at the 2019 80s guidelines on menopause, some really interesting scoping reviews on gynecologic disorders from PubMed.
And we also have practical clinical data and regulatory documents from the Care Quality Commission, the CQC.
Right, the CQC.
Yeah.
Because to do this properly, we have to explore not just the mechanics of the O shot itself, but like why biological regenerative medicine is becoming such a crucial lifeline in women's health.
Exactly. Because before we can understand why a totally new, frankly, intense-sounding treatment is gaining traction, we really need to understand the physiological reality of the problem.
Yeah, because menopause isn't just hot flashes and night sweats. We are talking about something called the Genitourinary Syndrome of Menopause, or GSM.
And the data shows this affects roughly half of all postmenopausal women.
Half. I mean, that is a staggering public health issue that just, it largely goes unspoken.
It really does. And the biological mechanics behind GSM are driven by a severe systemic deficiency in estrogen. When your estrogen levels plummet, the physical architecture of the vaginal and urogenital tissue essentially collapses.
Yeah, I was looking at the clinical breakdown of what that collapse actually entails. You see significant thinning of the vaginal epithelium. The tissue just loses its elasticity.
And the natural lactobacillus bacteria deplete.
Right, which causes the vaginal pH to increase, moving it out of its protective acidic state, and that collectively elevates the risk of infections.
It creates a highly fragile microenvironment. And perhaps most distressing for the patient experiencing it, that severe dryness and tissue thinning leads directly to dyspareunia.
Which is chronic, painful intercourse.
Exactly. The tissue becomes so delicate that normal friction causes microtears and severe inflammation.
Okay, let me jump in here with some logical pushback. Because if my car is low on oil, the dashboard light comes on and I just add oil. It's a simple mechanical fix.
Right, a direct replacement.
Yeah. So if a woman is low on estrogen, and we know that's the root cause of this tissue collapse, why not just give her local estrogen creams or systemic hormone replacement therapy like HRT? Why are we reinventing the wheel with totally new non-hormonal injections?
Well, on paper, that is the most logical approach. And local estrogen therapy and systemic HRT are still widely considered the gold standard.
But there's a catch.
A big one. The complication arises when we look at the long-term risk profile, which is highly complex and, frankly, not universally safe.
Which brings us to the 2019 Ladies E guideline surveillance report we have in our sources. The National Institute for Health and Care Excellence initially wasn't going to update their menopause guidelines at all, right?
They felt the existing evidence on HRT was sufficient.
But then
a major drug safety update was published by the Medicines and Healthcare Products Regulatory Agency, the MHRA.
Yeah, they analyzed an enormous new epidemiological study looking specifically at the risk of breast cancer associated with HRT.
And what they found was deeply concerning. We mentioned it at the top of the show.
Right. The MHRA update highlighted that some excess risk of breast cancer with systemic HRT actually persists for more than 10 years after stopping the therapy.
10 years of lingering risk. I mean, the total increased risk of breast cancer associated with HRT turned out to be higher than previous historical estimates.
Wow.
Now, across all the identified studies, there are some inconsistencies in the exact size of the effect. For instance, one massive study involving over 1 million women showed slightly smaller effect sizes than another study tracking 500,000.
Okay, so the numbers vary a bit.
Yeah, but the underlying undeniable fact remains. The risk profile is real, and it is enduring.
So think about what that means for the patient sitting in the consultation room. You are suffering from debilitating tissue degeneration, and yet for a massive group of women,
Specifically breast cancer survivors.
right, breast cancer survivors or those with hormone-dependent cancers who are taking medications like aromatase inhibitors, for them, estrogen therapies are strictly contraindicated.
Exactly. The doctor has to look at you and say, the gold standard treatment isn't safe for you.
It creates a massive gap in care. You are essentially leaving millions of women stranded without a viable pharmaceutical option to repair their bodies.
It sounds incredibly frustrating. You're just totally out of options.
Which is exactly the gap that biological regenerative medicine is trying to fill. If introducing exogenous hormones isn't safe, we have to look elsewhere. So, okay, let's unpack this. Enter the O shot.
Right. So the O shot is a specific standardized protocol originally developed by Dr. Charles Runels. It is a non-surgical treatment that utilizes platelet-rich plasma, or PRP.
And PRP is not a drug, right? It's not synthesized in a pharmaceutical lab by some massive corporation.
No, and that is the fundamental shift in the approach to healing here. PRP is an autologous treatment.
Meaning from yourself.
Exactly. Autologous means it is derived entirely from the patient's own body, specifically their own blood.
Okay, walk me through the biology here. The patient comes in, and there is a standard blood draw. And I know the blood is placed into a centrifuge, and since you listening probably know your way around a lab concept, we know the centrifuge separates the components by density.
Right, it spins it down.
Yeah, so you remove the red blood cells. But what exactly are we left with?
You are left with the plasma, but specifically, you isolate what's called the buffy coat and the platelet-rich layer.
A buffy coat.
Yeah. Through that centrifugation process, the plasma becomes concentrated with platelets at a level 5 to 10 times higher than your baseline whole blood.
Okay, I love an analogy, so think of it this way. Imagine a building that's falling apart. The drywall is crumbling, the pipes are leaking. Normally, your body sends a few maintenance workers, your circulating platelets, through the bloodstream to slowly patch things up.
A very slow process.
Right, but concentrating the plasma is like gathering an elite biological construction crew, packing them into one transport vehicle, and dropping them directly onto the demolition site. You're totally bypassing the body's normal, slower routing systems.
That visualization captures the mechanism perfectly. And the reason this elite crew is so effective is because of what they carry with them.
Oh, right, the toolboxes.
Exactly. Platelets contain structures called alpha granules. Think of alpha granules as the individual toolboxes carried by your construction workers.
And what's in the toolboxes?
When the platelets are activated at the injection site, those alpha granules degranulate. They basically open up and release a massive payload of bioactive molecules called growth factors.
Yeah, I was looking at the breakdown of these specific growth factors in our scoping reviews. We have PDGF, TGF-beta, and VEGF.
Right.
If I understand the mechanism right, VEGF, for example, is vascular endothelial growth factor. It is literally forcing the local tissue to build brand new blood vessels from scratch, right?
That is the precise mechanism. It's called angiogenesis. You are introducing a biological command to the local cells. You also mentioned PDGF, which is platelet-derived growth factor that stimulates cellular proliferation.
And the sources mention that these factors stimulate fibroblasts. Wait, fibroblasts, those are essentially the cellular factories that pump out structural proteins like collagen and elastin, right?
They are the heavy machinery of tissue repair, yeah.
Yeah.
By stimulating the fibroblasts, you are synthesizing new, robust collagen to replace the thinned, fragile tissue.
Wow.
And the growth factors also encourage nerve sprouting, which restores tactile sensation. So you have new blood vessels bringing oxygen and nutrients, new collagen providing structural integrity, and new nerve endings restoring feeling.
Which means the tissue naturally improves in mucosal hydration and elasticity. It rebuilds the physical structure that was lost to menopause, entirely without introducing any foreign hormones into the patient's system.
It relies entirely on the body's innate healing pathways. It's just amplified and hyperlocalized to the areas suffering from that estrogen drop.
Biological theory is fascinating, but if I'm a patient navigating these symptoms, I really only care about one thing. Does it actually work?
The ultimate question.
Yeah. Does this biological blueprint translate to real-world measurable symptom relief?
The clinical evidence synthesized in the scoping reviews provides a highly compelling answer. Across multiple study designs, including randomized controlled trials, cohort studies, and case series, the clinical findings show clear, statistically significant improvements.
I want to dig into how they actually measure that, though, because you can't just put a broken bone on an X-ray here. The studies mention using validated clinical scales, specifically the Vaginal Health Index, the VHI, and the Female Sexual Function Index, the FSFI.
Right. Those are standard metrics.
What do those scales actually track, practically speaking?
So the VHI is a clinical assessment performed by the physician. They are scoring 5 specific parameters: vaginal moisture, fluid volume, elasticity, pH level, and epithelial integrity.
Okay, so very physical, observable signs.
Exactly. And the data shows that PRP effectively reverses vaginal atrophy across all those parameters. The tissue becomes thicker, the natural lubrication increases, and the pH normalizes.
And the FSFI is patient-reported, right?
Correct. It tracks the patient's subjective experience across domains like desire, arousal, lubrication, orgasm, satisfaction, and pain.
And the pain scores went down.
The scores for dyspareunia, that painful intercourse we discussed, plummeted following PRP treatment
Yeah.
because the underlying tissue architecture was no longer fragile and inflamed.
That is incredible. And there's another fascinating application here. The data shows it helps with mild stress urinary incontinence, or SUI.
Yes.
The dreaded sneezing leak. I mean, anyone who has ever been afraid to jump on a trampoline or sneeze in public knows exactly what we were talking about here.
It is an incredibly common consequence of pelvic floor and tissue weakening during menopause.
So how does an injection into the vaginal tissue stop a bladder leak? I don't quite get the connection.
It comes down to mechanical support. The regeneration of collagen and those new blood vessels we talked about actually thickens and strengthens the anterior vaginal wall, as well as the tissue directly surrounding the urethra.
Oh, I see.
Yeah, by reinforcing that foundational tissue, it provides better mechanical support for the bladder sphincter. That helps it stay closed under sudden pressure, like a sneeze or a cough.
Here is where the data gets deeply resonant for me, though. We talked earlier about that specific group of women, the breast cancer survivors, who are completely out of options because HRT is contraindicated for them.
Right.
Does this work for them?
It does. We have a specific, highly impactful, single-arm pilot study in our sources that addresses this exact population. It involved breast cancer survivors, ranging from stage 0 to stage 3 cancer.
Think about the biological paradox here. These are women whose bodies are being chemically forced into severe estrogen starvation by life-saving cancer drugs. And yet, injecting their own concentrated blood into the local tissue manages to reverse the physical degeneration anyway. That is wild. Tell me about the protocol for that study.
Well, these patients reported severe vaginal dryness, often accompanied by dyspareunia. They were given a one-time treatment of just 7 milliliters of autologous PRP.
Wait, 7 milliliters is a tiny amount of liquid. It's barely a teaspoon and a half.
But it is highly concentrated, and here's the clinical technique. That small volume was injected into 35 different sites throughout the vaginal canal and the posterior fourchette.
The posterior what?
The posterior fourchette, that's the highly sensitive fold of skin at the very back of the vaginal opening.
Okay, but 35 different injection sites. I'm going to be honest, that sounds intensely uncomfortable. Why 35? Why not just do 1 or 2 larger injections and be done with it?
It comes down to the diffusion radius of growth factors in dense tissue. Those bioactive molecules don't travel very far from the injection site.
Oh, so they stay where you put them.
Exactly. If you do one large injection, you only heal a localized pocket of tissue. To ensure total, uniform coverage of the entire mucosal surface, the clinician has to create a meticulous grid distributing tiny microdroplets across all 35 sites.
That makes biological sense. You need the elite construction crew spread out across the whole demolition site, not just huddled in one corner on a coffee break.
Great way to put it.
So what were the results for these survivors?
At the 6-month follow-up, the treatment significantly improved their GSM symptoms, their urinary distress, and their overall sexual function.
Wow.
And crucially, this success included the patients who were actively taking aromatase inhibitors, the very drugs that severely suppress systemic estrogen.
To have a regenerative tool that works even when the patient's body is actively being chemically blocked from producing the hormone, I mean, that is a massive breakthrough.
What that looks like in practice is a complete conceptual shift. Traditional HRT and localized PRP are doing 2 fundamentally different things.
How?
Well, HRT manages the systemic chemical balances of the body. It replaces the missing signal from the top down. PRP, on the other hand, actually repairs the localized tissue architecture from the bottom up.
So they aren't necessarily in competition with each other.
Not at all. For women who can safely take HRT, Managing the systemic hormones while using PRP to repair the localized damage can be highly complementary. It is an inside-out and outside-in approach.
Okay, so we have this powerful regenerative effect. But introducing super concentrated biological material into highly sensitive, already inflamed tissue sounds like a recipe for a massive immune response.
You'd think so, yeah.
How does the body not just completely reject this? Let's talk about the logistics and safety, because if you're listening to this and thinking, this sounds like exactly what I need, you need to know what it's actually like to get this treatment.
Right. And the safety profile is actually one of the strongest arguments for PRP. It directly answers your question about the immune response. Because it is autologous, because it utilizes your own blood, the risk of allergic reactions, immunological rejection, or foreign body response is virtually zero.
Because the body inherently recognizes its own tissue.
Exactly. The immune system sees the platelets and says, oh, it's just us. Let them work.
Okay, that makes sense.
The adverse effects reported in the clinical studies are incredibly mild. They are generally limited to transient injection site pain or minor, temporary discomfort for the procedure itself.
And based on the clinical protocols provided in the sources, the actual logistics are fairly straightforward. It is an in-office procedure that typically takes about 30 to 60 minutes from start to finish.
Very quick.
Yeah, and that includes the blood draw, the centrifuge spinning to isolate the buffy coat, and the actual grid of injections.
And while it involves injections into highly sensitive areas, the protocols dictate the use of local anesthesia or compounded numbing creams.
Oh, thank goodness.
Yeah, the downtime is minimal. Most patients resume normal daily activities almost immediately.
But, and this is a critical but for managing expectations, it is not a magic instant fix. You don't walk out of the clinic 30 minutes later with brand new, fully functioning tissue.
That is a vital point for patients to understand. Because we are relying on biological regeneration, the timeline is strictly tied to the body's natural cellular turnover.
You can't rush angiogenesis.
Exactly. Results typically take 4 to 6 weeks to become truly apparent as that new collagen forms and those new blood vessels actually sprout and mature.
The sources note that the benefits generally peak at about the 3-month mark. And it's important to clarify that this is not a permanent one-and-done cure, right? The underlying aging process, the systemic reality of menopause, it doesn't stop.
Right. The clinical reports suggest the benefits of a single treatment generally last around 6 to 12 months, though this varies significantly by individual metabolism and severity of symptoms.
So it's an ongoing thing.
Yeah, this means patients need to view this as an annual or biannual maintenance therapy to suspend the tissue health.
I do want to point out a crucial regulatory detail we found in the Care Quality Commission, the CQC source, because when you hear about PRP in popular culture, you often hear about vampire facials in spas or athletes getting it in their knees.
Oh, definitely.
It can sound cosmetic, almost like a wellness fad, but the CQC is very clear that the O-shot is not just an aesthetic spa treatment.
The regulatory distinction is paramount here.
Yeah. Under the CQC guidelines, when PRP is used specifically to treat a disease, disorder, or injury, which genitourinary syndrome of menopause and stress urinary incontinence absolutely are, and when it is performed or supervised by a listed healthcare professional, it is classified as a strictly regulated medical activity.
The CQC cares about that distinction because it completely separates legitimate clinical interventions from vanity projects. When it crosses the line into treating a disorder, it demands clinical oversight, proper infection control protocols, sterile environments, and medically trained personnel. It validates the therapy as a serious medical tool.
So what does this all mean for you listening? Whether you are navigating the often frustrating transition of menopause yourself, whether you're supporting a partner going through it, or if you're just incredibly curious about where the bleeding edge of medical advancement is heading.
It's empowering.
It really is. Knowing that there are regenerative, hormone-free tools available to treat genuinely debilitating symptoms is incredibly empowering. It fundamentally prevents that hopeless feeling of being stuck when traditional options fail, or when your medical history takes the gold standard off the table entirely.
It represents a profound shift in how we approach aging and tissue decline. We are moving from simply managing the symptoms of a decline to actively demanding cellular repair using our own biology.
Exactly.
But if we look closely at the mechanism we've unpacked today, it does leave us with a rather profound question to consider.
Oh, I know exactly where you're going with this. It's the variable we haven't talked about yet.
Right. Since PRP relies entirely on the quality and concentration of the growth factors extracted from your own blood, how might a patient's overall health Their daily diet, their systemic inflammation levels, and their biological age at the exact moment of that blood draw impact the ultimate effectiveness of the treatment.
I mean, if the therapy is an elite biological construction crew, is that crew only as strong, only as well equipped, and only as capable as your current daily lifestyle allows them to be?
Exactly.
If your blood is carrying high levels of stress hormones or inflammatory markers, does that compromise the blueprint?
It suggests that regenerative medicine isn't just a passive treatment you receive on a Tuesday afternoon. It might be deeply, inextricably intertwined with how you live every single day leading up to that blood draw.
It's a fascinating thought, and it brings us right back to where we started. The medical landscape for women's health isn't always a clean binary equation. It is complex, it is deeply systemic, and it requires us to rethink what constitutes medicine. Absolutely.
But as we've seen today, even when the standard options are taken off the table, the biology of our own bodies might just hold the exact tools we need to rebuild.